Next, we want to welcome Dr. Lindsay Burrage from Baylor College of Medicine. She was a 2014 recipient of the NUCDF Fellowship Award. She's currently studying the long-term complications of UCDs and developing new ways to manage these disorders. She's going to be speaking this morning, New Insights on Liver Disease and UCDs.
I'd like to begin by thanking the NUCDF leadership for giving me this opportunity to talk to you today about our work. But also, I wanted to start by thanking the patients and families because you're making this work possible and really helping us to move the care and management of patients with UCDs forward. So, as was mentioned, today I'm going to talk to you about one of our interests, which is chronic liver disease and urea cycle disorders. So, I'm going to begin with the basics and we'll start with what does the liver do. And the liver does a lot of things, but we'll point out some of a subset of some of those jobs. The most important one that we talk about here all the time is the detoxification of ammonia, so getting rid of ammonia safely. But the liver does a lot of other things. It removes toxins from the blood and helps fight infections. It produces cholesterol, stores vitamins and minerals, produces bile, produces proteins that are, some of which are really important to make your blood clot. It breaks down food to produce energy, stores sugar, and we could list many more. So what are the signs and symptoms of severe liver disease? Well, you know, in medical school, we learn about yellow color to the skin or the eyes, abdominal pain, swelling in the legs, itchy skin, dark urine, pale stool, blood or tar-colored stool, chronic fatigue, nausea, vomiting, loss of appetite, easy bleeding, easy bruising. But really, these signs and symptoms typically only occur once the liver is really severely damaged, and milder forms of liver disease may be associated with no signs or symptoms that are easily recognized. And so most of our patients with UCDs don't show these kinds of symptoms from liver disease, and so we're trying to look for this liver disease that's silent, that may not show through signs or symptoms. So there are, the urea cycle, the entire cycle exists in the liver. And we know that there are different forms of liver disease that can be associated with urea cycle disorders. So we know that there are patients with UCDs, particularly OTC deficiency, who maybe their first signs and symptoms of the diagnosis is what we call acute liver failure. The liver, it gets really sick, over a short period of time, and once we diagnose the UCD, we can often treat and manage that, and it often improves. But today, my focus is going to be on chronic forms of liver disease. The most severe form would be chronic liver failure. But there are intermediate forms in there that are somewhere in between. And how can we tell if a patient has liver disease if, as I mentioned before, there are no real signs or symptoms? So there are different ways we can do that clinically. During the exam, when your doctor examines you, they check the liver size. Maybe they'll notice that the liver's bigger than we expect. That could be a sign of liver disease. Maybe they'll do an ultrasound of the liver and see that there are some abnormalities in the ultrasound or an imaging study of the liver. What we commonly do is use blood work. So one of the measures that helps us figure out if a patient might have liver disease are some enzymes called AST and ALT that spill out into the bloodstream when the cells in the liver are damaged. So I'm going to start by telling you about some work we did in the longitudinal study looking at AST and ALT as markers for liver disease in patients with urea cycle disorders. So we did this several years ago, and what we did is we collected the results from the blood work in the longitudinal study. And we determined how many patients with each individual urea cycle disorder had elevated levels of the liver enzymes at 2 or more visits. So because we're interested in chronic liver disease, we wanted to capture those patients who had elevations over time, not just at a one-time visit. And again, as a reminder, these are those AST and ALT levels that we get in the blood. And so what did we learn when we did this? So I'm going to walk through the data. I'm first going to show you the data for ALT. And we had to first come up with a cutoff. How are we going to decide if a patient has elevated ALT or not? And we picked a pretty generous cutoff. We picked about 2.5 times the upper limit of normal, which is around 100. So how many patients had more than one ALT level greater than 100, which I'm showing in blue, greater than 150, which is red, and greater than 200, which is gray. And what you can see when we did this, I don't know if you can see my arrow, we didn't see a lot of patients who fit this definition with OTC deficiency, but as we started to look at the more distal disorders like citrullinemia or ASS1 deficiency, ASL, and arginase deficiency, we started to see more and more patients who had this measure of chronic liver disease. And when we looked at the other enzyme, AST, we saw similar patterns. And so it seemed that chronic elevation of liver enzymes is more common in the distal disorders such as ASL deficiency and arginase deficiency. However, it doesn't tell the whole story because we used a pretty generous cutoff of 2.5 times the upper limit of normal. And this doesn't capture the patients who maybe have repeated ALT or AST in the 60s, 70s, 80s. We really focused on the higher levels, so just something to keep in mind. So what did we learn from this? Well, patients with ASL deficiency who had a history of high ammonia level and need for medications for that were more likely to have elevated liver enzymes. Elevated liver enzymes may be more common in patients with more severe forms of ASL deficiency, but the long-term effects or what this means for the patient is really unknown. So we can look at the liver on exam, we can look through imaging, we can look through blood work. How else can we diagnose liver disease, and how else can we figure out what this elevation in AST and ALT is maybe telling us? Well, one of the forms of liver disease that we worry the most about in urea cycle disorders is something called fibrosis or cirrhosis. This is a hardening of the liver. You can see the liver kind of takes that kind of cobblestone appearance. The challenge for that, though, is in order to figure out if a patient has this fibrosis or cirrhosis, the only real way we can do that is to take a piece of liver and look under the microscope to know if the patient's liver has this appearance. There's no other really way to tell that, so we only have tissue from patients who've had a transplant, or in rare cases, patients who've had a biopsy for some reason. But we don't take liver biopsies from our patients very much anymore, and so the only way we can really kind of figure out if a patient might have this fibrosis or cirrhosis is to go back and look at livers from patients who've been transplanted. And so we did a study within the Urea Cycle Disorders Consortium where we went back and looked at liver biopsies, which we only had a handful of those, but also tissue that was removed, the liver tissue that was removed when patients were transplanted. And we did this at Baylor and at Stanford. And what we did is we worked with pathologists who looked under the microscope and looked at that liver tissue and then counted up how many of those individuals had signs of liver fibrosis or cirrhosis. And when we did that, we found that we had 67 samples from 66 people who had a transplant with a UCD, and 61% of those samples showed no signs of liver fibrosis. But the flip side is that 39% did show some signs of fibrosis. So fibrosis can take many forms. There are mild forms and there are more severe forms. So we worked with the liver doctors to try to figure out how many of the patients had mild forms of fibrosis that may be less worrisome versus more severe forms. And what we found was that 17% of individuals had mild fibrosis in their liver, whereas 23% had what the liver team called clinically significant fibrosis. And what was striking to us is when we went back and looked to see which of the patients, which diagnoses seemed to have the most clinically significant fibrosis. There were 15 of our patients who had that. 12 of those 15 patients had ASL deficiency. So this seemed to be a problem that may be more prevalent in patients with ASL deficiency. So we went to the smaller population of patients with ASL deficiency. Again, these are all patients who had a transplant. They had a transplant for some reason. So it's not a perfect sample, but it's all we have. And so when we looked at the 15 patients who had liver tissue available from a transplant with ASL deficiency, 80% of them had clinically significant fibrosis. This was rare in other disorders. We did see it a few times in other disorders, but it seemed to be more common in our ASL deficiency population. What was striking to us is not only did our oldest patient, who was an adult, have clinically significant fibrosis in this study, but even our youngest patient, who was less than a year of age, had clinically significant fibrosis at the time of the transplant. So what does this look like under the microscope? Here are just two examples of what the liver looks like under the microscope. And you see a lot of pink, but the fibrosis is the dark blue or dark purple part. You can, I don't know if you can see my arrow, but all of this kind of purpley part shouldn't be there. And you can see what this looks like in one of our children's samples and then one of our adults' samples as well. So what did we learn from this study? Well, patients, it seems that in both studies, patients with ASL deficiency appear to have a higher risk of elevated liver enzymes, as well as hardening of the liver based on the liver enzyme elevation, the elevated AST and ALT, which is somewhat easy to check, but also in the fibrosis study, which required a piece of tissue to look under the microscope, that's much harder to check. And I think it's important, though, that we do have some caveats, some things that we have to think about. This is the fibrosis study, the liver tissue study, was a very unique population. These are patients who had a transplant. So there were factors that went into making that decision for transplant. And so I can't say with certainty that that population represents the patients maybe sitting here with ASL deficiency who haven't had a transplant. But does this mean that patients with other disorders do not have to worry about liver disease? And I think that's a big no. I don't think we've only started to look at one type or two types of liver disease. First, there were some individuals with other UCDs that had evidence of liver disease in both of these studies, but we're also not looking at every type yet. So the next thing we want to do is look at the stored fat in the liver. That's another kind of liver disease, fatty liver, and that's kind of one of our next steps. So again, what questions this makes us ask, though, is if we need to get a piece of tissue in order to tell if a patient has fibrosis or cirrhosis, that's not ideal. We want to come up with ways where we can figure out which patients are at risk for this without taking a piece of their liver. So we're trying to figure out if there are ways we can do this non-invasively through blood work or imaging. So that way we can be able to tell patients whether they're in the 80%, like the 80% of patients with fibrosis with ASL deficiency versus the other 20% that did not. So what are our next steps? So we're currently doing a study within the Urea Cycle Disorder Consortium to try to explore new tools for assessing the liver so that we, in the future, don't have to get a piece of tissue to diagnose fibrosis or cirrhosis. First, we're looking at special ultrasound methods that look at liver stiffness because the liver gets stiffer when there's fibrosis present. And then we're also looking at special blood work that tests markers of liver fibrosis, and we're exploring whether this might help us as well. These studies are all ongoing, and certainly if you're interested, please reach out to us, and we hope to have some data from these studies in coming years. And certainly patients who are considering transplant are a unique group that we're interested in studying because this is the one group where we can do these studies, and then when tissue becomes available after their transplant, we have a comparison to see how well they worked. So to summarize what we've talked about today, it seems that all individuals with UCDs likely have some risk for some liver disease, but at least for the two types of liver disease that we studied and that I talked about today, elevated AST and ALT and stiffening of the liver or fibrosis, it seems that the individuals with ASL deficiency seem to have the higher risk as compared to other UCDs. We are exploring whether there are new tools that we can use to measure fibrosis without taking a piece of liver tissue. And I think perhaps the most important take-home point is that individuals with UCDs may want to talk with their metabolic providers and their local providers of how they can keep their liver as healthy as possible. Things like maintaining a healthy body weight, because we know that overweight and obesity is an independent risk factor for liver disease in the healthy in adults and children, healthy populations. And we know that making sure the immunizations are up to date to try to protect from hepatitis or other risks that are a secondary risk for liver disease, as well as considering avoiding medications that are toxic for the liver, et cetera. So this is a good way to talk about liver health with your local provider, because that's something we can do now. So with that, I'd like to acknowledge the members of my laboratory, especially Saima, our nurse practitioner and study coordinator, who's driven a lot of this work forward. Thank you. We couldn't do any of this work without her. Our colleagues at Baylor and Texas Children's, the liver team, Dr. Leung and Schneider, who are still continuing to teach us about liver disease and UCDs and working with us closely on that. Dr. Shady, the pathologist, who looked at all of the samples under the microscope for Baylor, and the rest of the team in pathology and liver transplant, and Dr. Goss, who did all of these transplants at Baylor. A Stanford team, including Dr. Hazard, the pathologist who looked at the samples there, all of our other participating sites, the UCDC consortium leadership, Cindy, Teresa, who've all been very supportive of our studies, the funding sources, and again, thank you to the patients and families, because you're really helping us learn more. Thank you.